بسم الله الرحمن الرحيم. برحب بحضراتكم في لقاء تاني النهارده في اليوم الثالث لمؤتمر بورسعيد الحادي عشر لحديث الولادة، والنهارده هنتكلم عن الالرجيك راينيتس. يعني طبعا هو موضوع يمكن كلنا بنقابله كتير، وسواء بيبقى فيه يعني اندر دايجنوزس او اوفر دايجنوز احيانا، والانتي هيستامينز واستخدامها والمحاذير بتاعتها والبينيفيتس بتاعها. فيمكن ده اللي هنتعرض له خلال الدقائق القادمة، وإن شاء الله مش هنطول مع حضراتكم. Allergic rhinitis is also known as hay fever. It's clinically defined as a symptomatic disorder of the nose induced by an IgE-mediated inflammation. وده طبعا اللي بيميز allergic rhinitis. It's IgE-mediated inflammation after allergen exposure of the membranes lining the nose. So allergen must be present to stimulate the allergic reaction. Inflammatory disorder of nasal mucosa characterized by pruritus, sneezing, rhinorrhea, nasal congestion, adversely affects social life, school performance, work productivity, especially in patients with severe disease. Loss of productivity, missed school and work days, and direct costs associated with treatment create substantial cost to society. Allergens everywhere around us, either in the plants or the insects or the invisible mites or the grass or the household animals like cats and dogs. Foods, of course, sometimes people with sunshine, sometimes with cold environment. So the allergic reaction, it's initiated by an allergen. This stimulates the B cells to release the plasma cells that release antibodies. And the antibodies will react with the mast cell to release the subsequent cells, release granules, and this release the mediators that initiate the symptoms of asthma or allergic rhinitis, like histamine and other chemicals, like T cells, B lymphocytes, mast cells, eosinophils, monocytes, macrophages, and the dendritic cells. All these are inflammatory cells that are actually, originally they are, their function is to defend the foreign material or foreign allergens to the body. But when there is an allergy, or the mechanism of allergy usually is that's created by allergens that usually don't use harm to most people, but some people who are allergic or atopic, the usual allergens release the mediators after the cells release. The mediators, mainly cytokines, chemokines, histamine, prostaglandins, leukotrienes. All of us are familiar with these names. And this will lead to IgE production, arming of mast cells that release mediators. Then clinical effects is the last step of the reaction. Of course, sometimes mild or moderate cases don't cause the same severity of symptom. Irritation of free nerve endings by the allergen causing itching and sneezing. These are characteristic of allergy, but not every sneezing, because this is a natural defense mechanism against any change in temperature, and this natural also in infants, but not only sneezing, not just sneezing, but frequent sneezing, irritating sneezing that causes the child to be in agony or in pain or in discomfort. Increased mucus production, rhinorrhea. Rhinorrhea that's caused by change of temperature, like we see some children during cold weather or going to school in the winter. Their nose is running for some time, but it stops. But if it's continuous for a long time, it's mostly allergy. Vasodilatation that gives the sensation of stiffness or congestion of the nose, increased vascular permeability that causes edema, and then closure of the nose and the airway. When you look at the nose, as we will see in the pictures, we see a characteristic look of edema of the nasal mucosa. Repetitive sneezing, as I told you, because we tell the mother usually you can diagnose allergic rhinitis more than us, because sometimes you examine the nose, sometimes you see congestion or see edema, or sometimes no. But the mother can notice the severe sneezing, the sneezing that continues for some times. The child who sneezes few times, four or five times, is much different than the child who is sneezing 40 or 50 or 60 times in the morning or during the day. Nasal congestion, water rhinorrhea, is different from the usual reaction to change in temperature, few drops from nose, but if it's continuous for a long time, and it's not common cold, because sometimes common cold is mistaken with allergy. With differentiation is with other symptoms of common cold, like continuity of symptoms, sore throat, sometimes fever if it's not the mild common cold, nasal pruritus, and it's very characteristic because if sees child itching his nose, so this is a common finding in allergic rhinitis. This look of the running nose, itching nose, and the rhinorrhea is characteristic for allergic rhinitis. This movement of the child in his nose is called allergic salute. He's rubbing his nose because it's itching. Allergic shiners, these are dark signs under the eye. This is characteristic of allergy. Sometimes you see children coming to you complaining of dark halos under the eyes. And there is different causes. Sometimes it's normal because children, almost our children don't sleep well now. They stay late at night watching TV, playing games during the COVID quarantine time. Many children staying home, nothing to do, no school, so they stay late, and their sleep rhythm is inverted, and sleep rhythm is not normal. Sometimes you see these dark hairs, but sometimes when you see this with other symptoms of allergic rhinitis, you can call it allergic shiners. The nasal turbinates, when you look inside the nose, and it's very simple to look inside the nose, only light to have a look, you can find that nasal turbinates are edematous, like in this picture. And they are edematous or swelling. This gives you idea about the allergic rhinitis. Allergic salute, as we said, rubbing the nose by the fingers from itching or irritation. And with some frequent rubbing, sometimes you see a line in the middle of the nose. This is called the line of Scheimer's. Other manifestation may be accompanied because if someone is atopic, you can see other symptoms of atopy like eye allergic conjunctivitis, ear symptoms, postnasal drip. Postnasal drip, if you look in the throat, sometimes you see postnasal drip, but it is only mucoid and not pus or purulent. It is not infection, it's due to allergic rhinitis. So it's different when you look in the throat and find postnasal discharge. You find it if it's thin, serous or mucoid, different than purulent. If purulent is infection inside the nose or sinus or so. But if it's mucoid and simple fluid, this is due to allergic rhinitis. Ear symptoms are accompanied either with allergy. Frequent allergy cause a blockage of the Eustachian tubes. Sometimes complain that hearing is affected. Sometimes complain that they feel like his ear is blocked. Sometimes he feel itching because the atopic child, atopic patient, sometimes it's a very frequent complaint. Many families come to complain that his child is rubbing his ear, and this is cause a concern. It's very frequent complaint. Sometimes it's natural, sometimes you wax, but sometimes the ear skin itself is allergic or irritating. It's part of atopy. So he have atopy, he has itching in his skin, including the ear skin. Okay, so ear symptom may be due to obstruction of Eustachian tube or itching. Severity of allergic rhinitis may be mild, intermittent, persistent, moderate to severe. And mild is mild symptoms. Sometimes change of temperature, you find this sneezing or some running nose and so, but symptoms are not severe. So we call it mild. So if it's mild, and we call it mild allergy, but no need for treatment, because these symptoms don't necessitate to give local treatment or antihistamine and so. Intermittent symptoms that come and goes, sometimes seasonal, sometimes due to allergen exposure, but it's not continuous. And this necessitates treatment when there is an exacerbation. Persistent symptoms, that's persistent most of the time, and this is usually due to an allergen present in the environment direct to the child, like bed mites, the mites in the bed, and the linen and the mattress and the pillow. These mites is very microscopic insects, and it causes a lot of allergy, like nasal allergy, asthma, and this very frequent cause of allergy or atopy. And the only preventive and very effective preventive measure is the sun. So putting the linen and the mat pillow in the sun, exposure to sunshine kills these mites and cuts off the allergy. It's very frequent. So the persistent, I suspect there is an antigen or allergen inside the home, at home, like there is like curtains, like bed linen, as I told you, like something put on the floor, like some fungi and so on, and this or animal like cats may be present in the home. So we find that symptoms are persistent, do not resolve, not like the intermittent, which mostly with the seasonal allergy. Moderate to severe, this is interfering usually with the usual life. So child cannot sit in the class, he cannot do his homework, he's embarrassed when he is in during a visit or among others. Sometimes people are afraid from him when he's sneezing all the time, running nose all the time. He became embarrassed. So the moderate to severe, this is critical and necessitate treatment, sometimes continuous treatment. Intermittent, we say it intermittent if it is less than 4 days a week, less than or less than 4 weeks. So if I find symptoms 2 to 3 up to 4 days a week, is called intermittent. So he's sneezing 2 3 days in the week, or less than 4 weeks duration. So it is intermittent. The persistent is continuous more than 4 days a week or more than continuous 4 weeks. This is called persistent and initiate more than usually no more than line of therapy, like nasal plus antihistamine and so. So the persistent or severe necessitate more than line. In the mild, you find normal sleep, no interference with sleep, no impairment of daily activities, no troublesome symptoms in untreated patients. So the mild does not annoys his child nor his family. So you find someone who is moving from place to place and sneezing when goes into a cold area, exposed to some smoke or dust, but most of the day he is normal, he is okay. It is a mild. It does not necessitate any treatment. Moderate to severe, there is disturbance of sleep. He cannot sleep well, nasal block, or sneezing a lot during night, block the nose, so this interfere with sleep. Impairment of daily activities, so cannot go to school. When he goes to school and sit in the class among his colleagues, he's sneezing a lot, running nose a lot. Everybody's worried about him, especially in the COVID era. People are worried from anybody who is sneezing or have running nose. So he cannot do his daily activity, or he's working in some office or something. The people around him are worried from sneezing, running nose, and so on. Also abnormal work, so people in work always cannot work in a proper way. The triangle of atopy, eczema, asthma, allergic rhinitis. Usually we have one or more. The atopic patient usually have one or more of these. So you have allergic rhinitis and maybe have asthma sometimes, eczema sometimes, and sometimes you find the symptoms in a period of his life. So he spent 2-3 years with eczema, then 2-3 years with allergic rhinitis, then 2-3 years with asthma. Yeah, so he changes the pattern of atopy frequently every few years. Sometimes it happens with the atopic patient. So atopy may show in different life periods with different symptoms. Allergic rhinitis may cause otitis media with effusion, either serous effusion or pus. Nasal polyp, this is a complication of allergic rhinitis. You find polyps, and this polyp causes more and more obstruction to the nasal passage. Sinusitis, sometimes with allergy, sinusitis start to occur, and when allergy is severe, sinusitis is continuous, then be complicated. Asthma or chronic obstructive pulmonary disease, because it's a natural occurrence of asthma with atopic or allergic rhinitis. Upper respiratory tract infection, because most of the time there is congestion, there's shortness also. It can be complicated, especially sinusitis or otitis media. So upper respiratory tract infection can accompany allergic rhinitis. Obstructive sleep disorder, because the allergy at the end of several years of allergy can cause the adenoids to be enlarged, so he get obstructive sleep disorder. This is critical or serious because it's not a simple matter. Allergic conjunctivitis, as I said, is a part of the atopy triangle, and the child with allergic rhinitis might develop allergic conjunctivitis, sometimes develop asthma in certain period of his life. So he might get allergic conjunctivitis too. Mechanism by which rhinitis could provoke or worse asthma, the nasobronchial reflex. The blocked nose leads to breathing through mouth, increasing direct challenge of lower airway with cold, dry air and allergens. As you know, the nose is filtering and warming air going to the respiratory system. So if he's opening his mouth all the time, he breathes cold air. And sometimes you find asthma provoked by cold currents. If it's cold currents, asthma is provoked. And we can differentiate the people with asthma from those who is bronchitis or infective causes. This is intermittent and caused by a provocative cause, then relieved after the cause is removed. Sometimes you see child when he's talking a lot or laughing or running, he get asthma, not only because of asthma of exercise, but maybe from the cold air coming into his trachea without passing through the nose. Possible inflammatory reflex between upper and lower airways. So all lead to asthma complicating allergic rhinitis. Now to the management, the best management, of course, to avoid allergen. And many times, if you avoid allergen, if you understand the allergen, you can avoid allergic rhinitis. Pharmacotherapy, of course, as a mode of treatment, direct treatment to the moderate or severe asthma, allergic rhinitis, and asthma, of course, and immunotherapy. Now, the role of antihistamines is to combat the histamine, because histamine is distributed in mast cells in all peripheral tissues of the body and basophils, and all those circulate in the blood. When it's released, the histamine, it causes inflammation by increasing vasodilatation. This is effect capillary permeability, causing smooth muscle contraction, mucus secretions, and parasympathetic nerve stimulation. So when histamine is released, it causes several effects from it: inflammation, and then running nose, vasodilatation. There will be inflammation and narrowing of airway also. So asthma may accompany the allergic reaction. As we know, there are different receptors of histamine: H1 receptor, H2 receptor, H3 receptor, and H4 receptors. We are all familiar with these, and the H1 receptors are present on the smooth muscles, on the vascular endothelial cells in the heart and CNS. The H2 receptors, we know them in the gastric parietal cells. H3 are found in CNS, and H4 recently, not very recently, but discovered after H1 and 2 and 3, and they are widely expressed in components of the immune system, such as spleen, thymus, and leukocytes. Every one of these may be involved in the mechanism of allergy, and the treatment is directly to the, when I know the relation between which type of H receptors and the symptoms do I have. If I got H1 receptor affected or attacked, I find allergies like allergic rhinitis and so on. So I give the sixth way the anti-allergic medication or antihistamines. H2 receptors, all we us know it, the stomach and gastritis and peptic ulcer, gastric ulcer, and so on, and is treated by the anti-H2. H3 by CNS, and it's present in many areas in CNS, and no treatment, but it may function to release histamine in CNS and have some effect, but it's not fully understood. And the H4, which is released, as I said, in reticuloendothelial system like spleen, thymus, and leukocytes, and this may be related to allergy in the same time, and sometimes with the autoimmune disease also. H1 and H2 receptors are those most commonly involved, and mostly we understand them and we are familiar with them. And sometimes when you treat the histamine releasing conditions and give antihistamine, some people treat H1 receptor with H2 receptor as we use ranitidine and so on. Sometimes they treat allergies because it acts on H2 receptor too, but now there is no ranitidine available. Now back to clinical use of antihistamines. We use it in all forms of allergy except asthma, of course. Allergic rhinitis, but not the common cold caused by infection. And now we can differentiate between allergy and common cold. Common cold is continues for many days. It's caused by mild infection by mild viruses like adenoviruses or coronavirus is a mild one. And this common cold is one I catch it by infection, but no fever, so it's not influenza or influenza-like infection. So antihistamine can treat allergic rhinitis. The symptom we say common cold. There is a misnomer or a conflict between the common cold we express ourselves about it and the common cold related to allergic rhinitis. I want to clarify this point. Neither of them is related to making clothes less or taking baths or going out or so. No, the common cold with no allergy is due to mild infection. Mild viruses and cause common cold, burned throat, running nose, sometimes drowsiness, very mild fever, very mild cough, and this goes without treatment. This is the common cold. It's usually due to infection. But the allergic rhinitis making running nose and sting from every now and then, they call it common cold. Some people explain it by going out, getting clothes less, going to swimming pool, going to the sea. But again, it's not cold, it is allergy. So there is allergic rhinitis, which is called wrongly common cold, but now we can express it like this because it's only treated with antihistamine. But if it's not allergy, I don't give antihistamine. This is differentiation. Allergic rhinitis, I can give antihistamines. Allergic skin, like eczema, of course, I give antihistamine. Urticaria, hives, I give antihistamines. Pruritus, sometimes you find insect bites. Some children, especially in the early summer, when they go out and get insect bites from open places and gardens and so, they get allergy, some sort of allergy. And you might give them antihistamine, of course, because it's very irritating and itching, and the child hurts his skin and get infected and so on. So we can give him antihistamine. And atopic dermatitis, as we said, is part of allergy or part of atopy. The last thing is anaphylactic reactions. I think we have discussed many times the anaphylaxis, anaphylactic reaction, and anaphylactic reaction can occur from insect bite or from drug or from pollution. But if anaphylactic reaction have no edema, like the airway edema and so, or generalized edema, I don't give corticosteroid, I give only antihistamine. So if anaphylactic reaction is not associated with edema, laryngeal, face, eye, skin, I don't give adrenaline nor corticosteroid, only antihistamine. But with edema, I can give with antihistamine, adrenaline, then corticosteroid, as we described in anaphylactic reaction due to any reason. Now, the antihistamine work on H1 or H2 receptors. There is drugs that act with or act to competitively inhibit H1 receptor from being affected by histamine. So it stops the histamine effect, causing the allergic symptoms. The H2 receptors, there are drugs also that compete with the H2 receptors, like, as we said, ranitidine, for example, famotidine, nizatidine, roxadidine, cimetidine, the first one. As we know, all we know that ranitidine is stopped from being distributed now, and the Ministry of Health and all countries outside stopped ranitidine for some time until more studies. So we lost a valuable antacid. And there are other alternatives we use in gastritis, and famotidine was one of them. And maybe you are familiar because you heard what President Trump was treated. They gave him famotidine, among other medications, weird one. Remdesivir, of course, but he took other medications that are weird. We don't know why. So medications that block H1 receptors, of course, they have many generations or antihistamine, like first generations, diphenhydramine, chlorpheniramine, meclizine, and so on. And there are second generation like cetirizine, loratadine, and toluene. Then the third generation is this loratadine, fexofenadine, and levocetirizine. And based on the chemical modification, the third generation is the most recently used in them. The difference between the three generations of antihistamines, the first generation, all of them act on H1 receptor. Now we are away from the stomach and H2. We are talking about H1 receptor and its affection by histamine. The H1 antihistamine generation, first generation, is less selective on H1. The second generation is a modification of first generation, but the third generation is highly selective. So it does not have effect on other organs with H receptors. The first generation blocks acetylcholine receptors in the body and causing severe side effects, among them sedation. So if you look at the table down, you can see that it crosses blood-brain barrier and causes sedative effects. And the old times, if you want to get child to sleep, you give him antihistamine from the first generation. But of course, this is dangerous. And sedative effect was among the unwanted side effects of first generation of antihistamines. And there all the time there were precautions. Don't drive when you take antihistamine from the first generation, of course, because of severe sedation it causes, because it crosses blood-brain barrier and acts on H1 receptors or H receptors, not only the H1. So it wasn't selective only to H1. It acts on H2 and H3 and H4. And sometimes in the very old days, some people were giving antihistamines to gastritis because the first generation was non-selective and was acting on H1, H2, H3, H4. So sometimes people described, and more than 25 years, I see some written papers about giving the first generation in gastritis because it acts on H1, H2. But of course, it's nonsense because it's cause sedation, it's non-selective. So the second generation was modification to be highly selective. We have affinity mostly on H1 receptors. Side effects are much less than the first generation, okay? And have almost no anticholinergic effect. We know all antihistamine have anticholinergic effects, okay? But it and so have less sedating effect and called less sedating antihistamine, less sedating antihistamines. The third generation is highly selective, active metabolized derivatives or active products, more effective than the two generation, the first generation, second generation, because it's highly selective to the H1 receptors, and called non-sedating antihistamine because it does not affect the CNS at all. So the third generation is the most recent and mostly used because it's highly selective to H1 receptors. The side effects of the antihistamines, the traditional ones, affecting the H1 receptors in the CNS, causing alertness, cognition, learning, memory, and psychomotor less, and so he's not alert, cannot drive, and so as we said, impairment, maybe with sedation. It has muscarinic effects because, as we said, it has anticholinergic effects, so might cause dry mouth, urinary retention, sinus tachycardia. It has serotonin, it acts on serotonin receptors, so increase appetite and increase weight gain. Some antihistamines in the old times were used as appetizers, but not used, of course, because harmful. It have alpha adrenergic receptor effect, so increase dyspneic and postural hypotension, cardiac ion channel effect, so it prolonged QT interval and may increase ventricular arrhythmia. In the United States, the H1 antihistamines are not approved, have never been approved, or have had approval withdrawn. So the antihistamines acting from the first generation is not approved right now. The World Allergy Organization recommendation was not to use older generation of antihistamine as their approval was withdrawn due to their side effects and safety issues. There was some antihistamines, sometimes you can find some ampoules from them now antihistaminic, may be used because it's acting rapidly, but of course it's not dangerous because we don't continue on oral like oral. But the first and second generation, especially first generation, was withdrawn from the market there. So they are not used. Now, what's new? The levocetirizine, like levohistam, is the newest antihistamine from the third generation. It has a rapid onset of action within 1 hour, long duration, so we can take it once daily, has anti-inflammatory effects, so it's beneficial in the pathogenesis or pathology of allergic rhinitis, inflammatory process that's caused by all the mediators we mentioned, reduce comorbidities as asthma, high safety profile, and use start can be from 6 months. Levocetirizine, 100% of histamine receptors are occupied with levocetirizine, so it combats them from the effect of histamine. Rapid onset, as we said, superior efficacy, and FDA approved from 6 months of age, and long duration for 24 hours. So it's approved from very early age. Effectiveness of modern antihistamines or treatment for treatment of allergic rhinitis. This is distributed in Allergology International. That study treatment of 4 antihistamines including levocetirizine alone or in combination with intranasal. As we said, in severe allergic rhinitis, we can use a combination from local corticosteroids in the nose with the oral antihistamines. And this monotherapy with levocetirizine was determined to be significantly more effective on lowering the total symptoms and the total nasal symptoms than the other antihistamine. Conclusion, levocetirizine asserted itself as the only antihistamine compared with others as significant in this analysis compared to others. And this study was done on 140,853 patients. 140,000 patients. The study authors recommend monotherapy with the new generation antihistamine, levocetirizine, especially in severe cases of allergic rhinitis. That's meaning that in severe cases, you might not use local corticosteroid in the nose. This other study talking about the evidence for clinical safety, efficacy, and parent and physician perception of levocetirizine for the treatment of children with allergic disease. And it's a real-life study over 4,581 children aged from 2 to 12 years from 424 primary care or specialist allergy clinics across 7 countries in Europe and Asia. So the study is widespread, and levohistam has positive impact on the child's quality of sleep, ability to function at school, and quality of school activities, as we see in these curves. And the quality of school activities, of course, is very important these days because many children are atopic. Atopy is very common and increasing in incidence all over the world, not only in some countries. All over the world, allergy is increasing, either due to pollution or the allergens we have talked about. The pets or house animals are becoming more and more common, pollution of the community, faulty habits, unhealthy habits, and so on. So very important, quality of school activities and ability to function in school in the middle and the lower part are better with the levohistam here. As we see the last column, it's better with levohistam than other antihistamines. This real study, real life study, real life meaning from different centers, different 7 countries, as we said. In children aged 2 to 12 years, levocetirizine is the only H1 antihistamine launched in the 21st century shown to lack clinically relevant adverse effects on physical and psychomotor development. So this is the only H1 antihistamine in the 21st century showing almost no or very little or insignificant effect on physical and psychomotor development. This comparative study of clinical efficacy and tolerability of 2nd generation antihistamine and 3rd generation, which is levocetirizine antihistamines, in seasonal allergic rhinitis. Seasonal, as we said, the allergic rhinitis is present many times seasonal. So we find people in the spring, people in the autumn have allergic rhinitis. So this showing cetirizine here in all columns that affect levocetirizine on nasal congestion, which is the sensation of obstructions. That's obstructions that awake a child from sleep, that cause him during the day to be annoyed from obstruction, and so on. So this generation or 3rd generation, and this product especially have minimum side effects, increased duration of action, positive effect on nasal airway, airflow, so no sense of obstruction, a reduction in nasal congestion, effect of leukotrienes on airways. As we said, asthma is related to allergic rhinitis, increased levels of leukotrienes في nasal fluid after allergen challenge. This cause asthma to be provoked. ده اللي الناس بتقول عليه ده كان في مناخيره بينزل على صدره. Okay. contribute to both early and late phase nasal congestion, sneezing, rhinorrhea, quality effects of leukotrienes on airways, chemotractant for eosinophils, so eosinophil come and make more inflammatory action, promote eosinophil adhesion, so eosinophil come and adhere, decrease eosinophilic apoptosis. Apoptosis, programmed cell death, so eosinophils does not caused to be apoptosis. Leukotriene inhibitors competitively block bind of leukotrienes to end organs. Montelukast is only FDA approved leukotriene inhibitor. Montelukast reduces in exhaled nitric oxide, and Montelukast acts through the airway. This agent is a good choice for asthma and allergic rhinitis, so we can give antihistamine with leukotrienes, because with Montelukast, because antihistamine can compete the histamine responsible for rhinorrhea, nasal itching, and sneezing, and the Montelukast can combat leukotrienes, which increase the nasal airway resistance and vascular permeability. So blockage or inhibition of these two mediator, histamine and leukotrienes, may provide additional benefit compared to single mediator inhibition. Intranasal steroids, we are talking about, or remedies of therapy for allergic rhinitis, are mostly local, thus avoid unwanted side effects associated with their oral or IV use. So we don't give oral corticosteroid to allergic rhinitis, never. New formulation of local corticosteroid in nose show even lower systemic absorption, most effective against late phase mediators with some effect on acute phase response. So it's protective more than early effect. First line drug in aerosol allergic and seasonal allergic rhinitis. But for perennial allergic rhinitis, management with inhaled steroids alone has not proved to be as beneficial. So it's not a magic treatment. Depending upon severity of disease, short courses of oral steroids in addition may be used, but very limited use, fewer side effects, of course, if you use local corticosteroid. Now, drug and symptom matrix, meaning when I put drugs like this, antihistamines, anticholinergic, corticosteroid, decongestant, mast cell stabilizer, anti-leukotrienes, I find sneezing is better controlled by antihistamines, corticosteroid, mast cell stabilizer, less with anti-leukotrienes. Itching, better with antihistamine, of course, better with corticosteroid. Rhinorrhea, better with anticholinergic, but it's not beneficial in other places, and there are some limited use, but antihistamine is better, of course. Corticosteroid, of course, in congestion, decongestant, but had its limitation and precaution. Anti-leukotrienes can be used effectively to make symptoms of congestion less. And the algorithm if you want to sum the all we talked about, the allergic rhinitis, if have mild symptoms, we might give oral histamine blocker, intranasal, maybe leukotriene modifier if it's mild. Moderate to severe, we can use intranasal steroids with histamine, antihistaminic, of course. A nasal hormone, maybe, was used in the past, but now less. Leukotriene modifier. Persistent symptom, this may use nasal steroids with antihistamine. Step down, of course, there are other remedies like increased dose of intranasal steroids, maybe other remedies, but now we are talking about antihistamine and local steroids mostly, and maybe anti-leukotriene we might be added. Thank you. I hope you enjoyed the talk.